Good afternoon, everyone. I'd like to welcome everyone back to our final session of Rocky Mountain Highlights today. I'm really excited for this session where our intention is to have a little bit of tug and pull. I'll spend the first portion of this session talking about areas in which we may need to start doing more with regards to colorectal cancer screening, and then we will get to hear from Dr. Stephen Edmundowitz about perhaps areas where we may actually benefit our patients by pulling back in what we're doing for colon cancer screening and colorectal neoplasia surveillance. So this first talk, I'd really like to address a topic that's gotten a lot of attention over the last few years, and that is this phenomenon of early age onset colon cancer, or colon cancer diagnosed in individuals under the age of 50. And my goal today is really to review the data that informs our current screening guidelines and to really start to talk about this issue of whether 45 is truly the new 50. These are my disclosures and have no conflict with the content that we'll be talking about today. So my objectives today will really be to review the epidemiology of colorectal cancer over the last several decades, the clinical and pathologic features of colon cancers that we are seeing in younger individuals, start to talk about why this phenomenon is happening, the etiology of early age onset colon cancer, as well as potential risk factors that have been identified, and finally spend the bulk of our time talking about our practical approach to decreasing disease burden in individuals under the age of 50. So colorectal cancer screening has been a great success in our country. We've seen a steady decrease in the incidence associated with colorectal cancer in every age group over the age of 50. Unfortunately, as many are aware, we've seen a steady increase in incidence in all decades under the age of 50. This issue has certainly gotten substantial attention by not just the medical community, but also the lay media, and continues to get attention as high-profile individuals in our society succumb to this disease. So what do we understand about colon cancer in those under the age of 50? Well, it is substantially burdensome. It's the second most common cancer and the third leading cause of cancer-related death. There's been a 51% increase in incidence since the mid-1990s and an 11% increase in mortality over the last decade. The vast majority of these colon cancers occur in those between the ages of 40 and 49. And what we're starting to see is that the proportion of colon and rectal cancers diagnosed in younger patients is occupying a larger and larger piece of the total pie of colon cancers that we take care of, such that right now, almost 30% of all rectal cancers that we're diagnosing are occurring in individuals under the age of 55. And when we look at incidence rates compared to 50-year-olds back in 1992, when we first started colorectal cancer screening more broadly, we see that they in fact are very similar to the incidence rates that we're currently seeing in 45 to 49-year-olds. There is a substantial increase in incidence across our country, but the incline has been steepest in the states depicted here, with southern states and Appalachian states seeing a sharper rise in the incidence compared to Western states. But it's not necessarily as simple as just macroscopic state-based geography. This recent study showed that the increase is actually steeper in rural populations than it is in urban populations. This is an international phenomenon, with the countries depicted under the red bars really showing a statistically significant increase in incidence rates compared to those few countries in blue where there's been a decrease, and the remaining countries where there's not been a significant change. What's really fascinating about the phenomenon is what we refer to as the birth cohort effect. And essentially, what that refers to is the impact of generation-specific risk factors, essentially ascribing a health outcome such as colorectal cancer incidence based on the year of birth. Becky Siegel used age period cohort modeling. And what she determined is that there's an influence of the birth cohort effect such that the incidence curves for those ages 50 to 54 in the United States appeared similar to older age groups from the 1970s to 1980s. But then there's an inflection point where it starts to reflect the curve seen in younger individuals starting in the mid-1990s. This suggests that there's essentially a birth cohort effect in contrast to a period cohort effect, which might be the effect of a change in clinical practice. And this birth cohort effect essentially suggests that younger cohorts, in fact, will carry this risk along with them as they age. So what do we know about colorectal cancer in young patients? Is it a different disease entity than colon cancer diagnosed in older individuals? Well, when we contrast large cohorts of those diagnosed before and after 50, we do see some interesting differences. Many of us who diagnose and care for these patients are not too surprised to see that the majority of young patients are diagnosed due to symptoms. There's unfortunately a significant delay from the time of symptom onset and the time of diagnosis in contrast to individuals over the age of 50. Not too surprisingly, individuals under the age of 50 are more likely to have a family history of colorectal cancer. What's really interesting is that the disease distribution in the colon appears to be much more dominant in the left colon, in particular, the rectum, where we tend to see early age onset colon cancers occur much more commonly in the rectum than later age onset colon cancers. These individuals have a much more advanced histologic profile with a higher rate of mucinous features, signet ring cells, poor or no differentiation, and they appear to have a very distinct molecular subtype. They're diagnosed at later stages of disease in contrast to matched older patients, but paradoxically actually have better survival matched by stage. So why is all of this happening? Well, when we look at all comers, all individuals under the age of 50 diagnosed with colon or rectal cancer and perform comprehensive germline genetic testing, as was done in this Ohio State study, 16% are found to have a pathogenic variant in a gene that's been associated with cancer risk. So what that leaves us is with 84% of individuals where comprehensive germline genetic testing does not identify a clear genetic diathesis to cancer. We suspect that approximately a quarter of all patients have some familial component. So even if a specific germline mutation is not identified, that there's family history that might be increasing risk. And certainly we all are aware of the data that any individual with a first-degree relative diagnosed with colon cancer, regardless of how young or old that first-degree relative is, has an over twofold increased risk of colon cancer compared to the general population without family history. And as you add more family members or younger family members, the odds approach almost fourfold increased risk. We also know that those with a first-degree relative with an advanced colorectal polyp, an advanced adenoma, have nearly identically high increased risk as compared to those with the first-degree relative with colon cancer. When looking at early age onset colon cancer, we've started to understand some of the factors associated with increased risk. This is really a summary of the most recent data, and albeit the data is limited when specifically focused on young patients, but we see some risk factors that appear to be shared compared to the risk factors that we are well aware of in older patients, such as sedentary lifestyle, features associated with metabolic syndrome, such as elevated triglycerides, obesity, steatosis, as well as more traditional risk factors in the older population, such as smoking, increased intake of processed meats, and excess alcohol use. What we're starting to also understand is that there may be unique risk factors, such as increased intake of sugar beverages, as well as a Western diet. So when we think about the etiology, there's a variety of different hypotheses as to why millennials, why young patients appear to be at increased risk of developing colon cancer. And when we think about the epidemiology of this disease, it certainly raises the regional variations in other disease burden that we see, such as the contribution of obesity, diabetes, metabolic syndrome, but also the international distribution and international burden of this disease in other Western countries raises the possibility of other shared risk factors. And certainly when we look at certain things like regional exposures, environmental exposures, ambient exposures, such as radiation exposure, it starts to beg the question of whether there's other components of our Western westernized lifestyle that might be increasing our long-term cancer risks. Along the same lines, when we start looking at the risk factors and think about this birth cohort effect, it starts to beg the question of what it is that is different about how our society has changed over the last several decades, and maybe even early exposures, early changes in our microbiota, such as a result of childhood antibiotics in the food chain, industrialization of our food industry, or even increase in inflammatory or atopic conditions that might potentially be contributing to this cancer risk. This still leaves many, many unanswered questions and quite a bit of important research that is yet to be done to truly understand why these rates of colon cancer are increasing in young individuals. And truly, it's likely a spectrum of risk over the course of really prenatal exposures all the way through adolescence and early adulthood that may very well be increasing our risk. As interesting as it is to hypothesize why this phenomenon is happening, it's important to talk about what our practical approach can be right now to decreasing our disease burden. I guess before we talk about that, to be a devil's advocate, we might want to actually consider whether we should do anything altogether. Yes, we see these curves going in the wrong direction for 20 to 49-year-olds compared to 50 to 64-year-olds, but I call your attention to the y-axis here and the magnitude of the problem. You can see that the absolute incidence rates in younger patients are significantly lower, orders of magnitude lower than the incidence rates observed in older individuals. So should we be doing anything at all? And when put side by side, these incidence rates are dwarfed by the incidence rates in older individuals. I would actually argue that it is incredibly important that we address this issue, and that is because younger individuals, as we can intuitively infer, have such an important contribution to our society as caregivers of not just younger generations, but also older generations, and really decades of contribution remaining to our society. And when quantified in modeling studies, we can see that the person years life lost for those diagnosed with colon cancer between the ages of 45 to 49, even though the absolute number of these individuals who succumb to this disease is much, much lower, the person years life lost almost approaches the person years life lost to all those who succumb to colorectal cancer between the ages of 65 to 69. And so it really does pose a substantial burden to our society. The other thing that I might point out is work out of Jordan Karlitz's group that showed that perhaps the incidence rates that we've been referring to, those y-axis numbers, are underestimations. This is a study where he looked at regional rates, incidence rates, and what's really kind of alarming is this sharp increase from age 49 to 50, strongly suggesting that there are subclinical cancers in the 45 to 49 age group that are not diagnosed because historically we have not screened this patient population. So I would argue that it's important that we address this phenomenon head on. What can we do? Well, there's many, many things that we can do, and we could spend an entire symposia reviewing all of these. It's important to promptly evaluate symptoms. Certainly important to continue our efforts at identifying those 16% of patients who may have a hereditary syndrome. Also to continue efforts at ensuring screening in those whom we know are at increased risk, such as those with a family history of colorectal cancer, a family history of advanced polyps, which as gastroenterologists, we don't do a great job of communicating that risk to our patients or their family members. And certainly Black patients or African Americans who we know are at increased risk. What I'd like to focus today's discussion on in the limited time that we have is to really talk about the recent recommendations by the United States Preventive Services Task Force about our approach to changing average risk colorectal cancer screening. So as we're all aware, it was in May of 2018 that the American Cancer Society was the first society to come out to suggest decreasing the average risk screening age from 50 to 45 as a conditional recommendation. Now, it's important to know that average risk refers to individuals with no family history of colon cancer and no symptoms. So this is just routine population-based screening. It was not until October of this past year that the United States Preventive Services Task Force came out with a draft recommendation also aligning with the ACS recommendations. And these recommendations were, of course, formalized in May of 2021, where now USPSTF recommends starting average risk screening at age 45 as a grade B recommendation. There are so many unanswered questions about expanding screening to this patient population. Does it work? What do we expect to find if we expand screening? Will our primary care colleagues be accepting of this change in recommendation? What about patients? Will they be accepting of screening starting at younger ages? Will they be compliant with screening? What about insurance coverage? A very important practical question. And are we sure we are actually benefiting our patients as opposed to exposing them to undue harm? And if all of that is addressed, do we even have the capacity to expand screening to younger individuals? Well, let's go through some of these and talk about the data that we have. Well, what do we expect to find if we were to expand screening to younger patients? This was a study out of the New Hampshire Colonoscopy Registry. And although they were not doing average risk screening in young patients, they essentially identified individuals who were average risk equivalents. And so those were individuals who were getting colonoscopy for diagnostic purposes that were low risk, such as change in bowel patterns, constipation. And what they found is that almost 4% of individuals 45 to 49 had an advanced colon polyp, and almost 18% had any colorectal neoplasia. What was really interesting from this study is that these rates were almost identical to the rates of neoplasia found in those ages 50 to 54. Dr. Jennifer Kolb published recently this systematic review meta-analysis, which included 17 international studies that strictly included only individuals undergoing colonoscopy who were average risk, and essentially found identical results to the Butterly paper, showing that 3.6% of individuals aged 45 to 49 had an advanced colorectal polyp, and 17.8% had any colorectal neoplastic polyp. And again, Jen was able to show that this rate was very similar to the rates observed in 50 to 59-year-olds. And one of the kind of striking conclusions from this study was that in order to find and remove one advanced colorectal polyp, we'd have to screen by colonoscopy 28 45 to 49-year-olds. That's in contrast to 24 50 to 59-year-olds. So it really starts to show us the power of prevention that we could have, that not only would we potentially diagnose colon cancers at an earlier age, as Jordan Karlitz's group showed with that spike from 49 to 50, but also we have this awesome power of colorectal polyp removal, and removing these advanced lesions would pay it forward in terms of colon cancer prevention for individuals in their late 40s and early 50s. Specific to the veteran population, Dr. Timothy Yen and Jack Scalaro have been working on describing the neoplasia rates in average risk individuals within the VA. And similarly, looking at average risk equivalent 45 to 49-year-olds, the rates of advanced colorectal polyps was essentially the same in those 45 to 49 compared to those age 50 to 54. So although the data is limited, the data we have suggests that expanding screening to 45 to 49-year-olds may have similar yield as current screening in 50 to 59-year-olds. What about the balance of potential risk, potential cost with benefit? Well, it's important to acknowledge that all of the data that we have is based on modeling studies. But I would like to remind the audience that it is microsimulation models that have informed average risk colon cancer screening options since the 1990s. And in fact, since 2008, these exact models have informed average risk screening for those over the age of 50 as well. So although there's no randomized controlled trials available for those under the age of 50, there really, as of yet, are no published randomized controlled trials for those over the age of 50 either. These three microsimulation models essentially compared screening average risk individuals age 45, age 50, or age 55 as a start age, and found that of the 57 strategies that were found to be efficient, 47 of them recommended starting screening at age 45. Every modality that was looked at, whether it be colonoscopy, CT colonography, flexible sigmoidoscopy, or stool-based testing, was found to show significant life years gained compared to starting at age 50. And shown another way, you can see that every single testing approach was associated with life years gained, colon cancers prevented, and colon cancer deaths averted. Now, of course, each of these is associated with increased testing use, and the USPSTF and these microsimulation models don't specifically look at cost, but indirectly look at resource utilization through these additional tests required. And of course, there are potential associated complications that we're seeing with each strategy. Well, what about cost? Yuri Lodabaum published this cost effectiveness study last year, and essentially was able to find that starting screening for our population in the US at age 45 would cost approximately $34,000 per quality adjusted life year. And if we actually implemented a stool-based screening program of annual FIT, that would cost approximately $7,700 per quality adjusted life year. Now, for those who are not accustomed to reading cost effectiveness studies or Markov modeling studies, just to give you some context as to what this cost means relative to other practices that are fairly well accepted in our society, annual mammograms starting at age 40 costs our society $58,000 per quality adjusted life year. And even if we were to pull back and be a little bit less aggressive with mammograms and start at age 50 and do them every 2 years, that screening strategy costs our society $34,000 per quality adjusted life year. So of course, these things are never a zero-sum game, but to provide some context, screening our patient population starting at age 45 does not appear to pose a really exorbitant amount of cost compared to the things that we currently already do. Well, what about capacity? This is a very important and true issue that we are all contending with in our hospital systems. The same study, Yuri essentially estimated that to expand screening, we would need to be able to have an additional capacity of 10.7 million colonoscopies if colonoscopy was the test of choice in the United States. Well, interestingly enough, when we look at our current annual colonoscopy volume and available annual colonoscopy volume, there is indeed that capacity available nationwide. But of course, the issue is not as simple when we start thinking about how the rubber might meet the road and how we can actually implement this change within our practices. This is just a recent poll of all the 45 to 50-year-olds within the UC Health system. And what we're talking about is essentially 150,000 patients who would immediately be eligible for some type of screening test. And when, as a GI group, we start to think about how we have the capacity to handle this, especially in the context of catching up on some delayed capacity through dealing with delays associated with COVID, it starts to feel a little overwhelming. Jason Dominitz recently shared this data with us regarding the VA population and essentially summarized that if we expanded screening, that would require us to screen an additional 280,000 45 to 49-year-old veterans. And our annual VA colonoscopy capacity at this point is just 282,000. And so expanding screening would put us into a zone where we are essentially being swamped by the demand for colonoscopy, if that's the test of choice that's pursued. What about our primary care colleagues? What do we know about their acceptance of expanding screening? Well, this was a very interesting survey study done by Dr. Anjali Parekh. And she surveyed primary care colleagues here in the University of Colorado system, including University of Colorado, the RMR VA, as well as Denver Health and affiliated satellite clinics. And many tuned into this webinar may have actually participated in the study. But very reassuringly, the vast majority of primary care colleagues agree that they would offer colon cancer screening to 40 to 49-year-olds who have a first-degree relative with colon cancer. In contrast, granted, this study was completed before the USPSTF came out with their recommendations, the vast majority really indicated that they would never or rarely consider screening 45 to 49-year-olds who are average risk or those with no family history. Importantly, however, primary care very much relies upon practice guidelines to inform their colon cancer screening practices. And so this really raises optimism that with the USPSTF guidelines, as our primary care colleagues absorb the data that is available, suggesting benefit over harm, that there wouldn't be a significant barrier from the provider's perspective at recommending this for our patients. What about insurance coverage? This is an extremely important practical issue. Insurance coverage and affordability are always concerns and potential barriers. This is out of the Kaiser Family Foundation that showed that up to half of patients who are uninsured avoid preventative services because of concerns due to cost. And you can see the breakdown of individuals who are underinsured or those at the federal poverty level and their avoidance of preventative services to save cost. Obviously, there are still so many unanswered questions and more data needed to inform a lot of these issues. And some that we haven't even really had a chance to talk about, and that is if we do expand screening, how do we do so in an equitable fashion? What type of tests should we be using? Should we be using the full menu of options as is currently recommended versus a tier approach or a hybrid approach where those 45 to 49 are offered a certain test and then after 50, a different test? What about precision screening based on risk scores, polygenic risk scores, or risk factor-based screening? And we still haven't answered the question of whether screening in prospective randomized controlled trials truly works. Despite that, this is where we stand as our current professional societies. As I mentioned, the American Cancer Society came out in front with their qualified recommendation in 2018. Why didn't practice change after that? Well, as many are aware, the really state-by-state variation in which guidelines are observed likely had a large part in this. And so the states in blue actually honored both the ACS guidelines as well as the USPSTF guidelines, whereas those in gray did not. And so you can see that the state of Colorado is one that since 2018 was not by legislation required to honor American Cancer Society guidelines. And so that might be why, as a region, we haven't seen a significant change up until recently. In the spring, the American College of Gastroenterology did their thorough evidence review and came to the conclusion that they also suggest expanding screening to 45-year-olds and older. And then, of course, everyone's aware that in May of 2021, the USPSTF published their grade B recommendation to do so. All of our professional societies have essentially started to fall in line in the subsequent months. We know that this is very, very important because for the Affordable Care Act, under the Affordable Care Act, private health plans must provide coverage for preventative services that are deemed to be a grade A or grade B recommendation by the USPSTF without any cost sharing imposed on our patients. So for an expensive screening test such as colonoscopy or a two-step screening test such as stool-based testing followed by a colonoscopy, this is incredibly important. And this USPSTF recommendation really provides the groundwork to overcome the cost and insurance barriers. As I mentioned, several other professional societies have started to align with these recommendations. The National Comprehensive Cancer Network updated their guidelines this year to also recommend screening for those age 45 and older. And in May of this year, the United States Multi-Society Task Force also sent out an alert, a member alert, suggesting that they will also publish recommendations soon that will be in line with recommending screening for average risk individuals starting at age 45. It's important that we don't take our eyes off the prize. It is, of course, important to focus on the issue of early age onset cancer, but also to acknowledge and full force continue efforts at improving screening for everyone who's eligible. As of 2016, less than 70% of eligible 50-plus-year-old Coloradans are up to date on screening. And when we look at screening stratified by age group, those age 50 to 54, only about half of eligible individuals are getting screened. So with this in mind, it's really important that we all acknowledge that it's not a zero-sum game. We can't necessarily focus our efforts on just one patient population in particular. We should always acknowledge and improve efforts at screening everyone who's eligible. So I thank you for your attention. Just some final closing thoughts. Early onset colon cancer is on the rise and it demands our immediate attention. The epidemiologic and clinical and pathologic observations that we see provide clues into the potential etiologies. And increasing disease burden does demand our immediate attention, and we will need to do ongoing work to ensure equitable access to screening for all who are eligible. I thank you for your attention. I am very much looking forward to a very lively discussion during the Q&A, but